something very subset of specialty where we deal with the heart surgeons, where we do something, we alter the physiology, which is you all learn normally. So where what we do for different conditions, the valve surgery or the bypasses, where the coronary artery should block, or then sometimes in traumatic and even malignant conditions. Okay, so these emergencies are usually our patients are immediate most of the mainly is happening in our ICUs most of the time, in our ICUs and hypertension units. But very rarely the echo 2 patient might come to the HQ where your critical care team may have involved. So if you see a cardiac operation, what we do usually, most of the operation be in an elective setup. So there the patient is there. So during our bachelor basics, patients are come with the pre-planned status, right? So they have set of conditions that was there. We may call them risk factors, right? So it's a being a male, female, or obesity, or something side related to either side of it, the hyponutrition or the hypernutrition status, either way. Okay, or else something called cholesterol and hypercholesterolemia, which can be familial or acquired conditions. Okay, and also sometimes they can have a bleeding disorders. They have on their own, or they were iatrogenically generated. We give the aspirin properly and sometimes even heparin, and sometimes we do the thrombolysis when they come in emergency setup. Okay, so in addition, they have the condition, the heart being already affected. So in the normal heart, as we know, there is a filling of the heart, we call it a preload. Then there is a heart pump gauge, that's afterload, and contractility. All these things has been altered because of the disease state of the heart. Okay, so these on admission, what is the state of the heart? How much injection fraction is here? What's the valve pathology? And single valve or multiple valve, or how the tissue perfusion to the heart itself by the coronary arteries. Okay, so it's all confirming coming as a patient on which we are going to operate. Okay, then one decided, we take the patient to the theater where we temporarily connect to the machine. We call heart-lung machine, right? We put one cannula to the aorta, distal aorta, and rather ascending aorta, and then we pump blood through that, and while we withdrawing the blood from the right atrium. Okay, so then what happens? The blood going to clot when it travels to the tube outside. To prevent that, we give heparin to the patient. Okay, so we know heparin, where does heparin act? It's act on antithrombic. Okay, so it's prevent thrombic formation rather blood formation. Okay, so and in addition, when we connect to the machine and we stop the heart for a while. So when you stop the heart for a while, what's the problem? It's organ very active during the lifetime. So when you stop, we have to prevent it's getting damaged because of our procedure. To do that, the myocardial demand, we have to bring down the myocardial demand, right? So we give the cardioplegia solution, so which contains hyperkalemia solution. In addition, we give with the blood to give the nourish the heart. Then we arrest the heart in a diastole. Okay, that means if you all remember your action potential graph in the hyperpolarized state. Okay, in addition, we bring down the temperature, normal body temperature to 32, 34 degrees. Sometimes even major operations and long surgeries, we bring down even 28 degrees Celsius. Okay, to minimum oxygen demand and tissue demand. Okay, to protect the myocardium. So all these things we do during our surgical procedure. In rather, you see, I think you must have gone to the leader trial. No? We induce the hypothermia and we induce the coagulopathy ourselves. So this is a patient going to come out of that. Then we will reverse this heparin effect and we repurpose the heart, and all these things will happening during short time frame. Then patient come to the intensive care unit to get further optimization. Okay, and hopefully most of the time these patients are all right, but they can have the residual effect. Okay, so this is what we are going to deal with for next half an hour. Okay, this is a patient, right? So anything you can interrupt and ask me, right? So, even though they talk about morbidity and mortality, but we are talking mainly, I think they are concerning on the bleeding related issues, right? So many things, right? So, as I outlined, what are the problems now? So, this is an ideal patient, what they're talking about, a 66-year-old man admitted to ICU after emergency CABG, coronary artery bypass valve operation, following cardiac catheter precision for unstable angina. The history include, he is an obese person, he is a heavy smoker, 45 years smoking, poorly controlled diabetic, hypertension, and the gout. And on admission, he is paralyzed, sedated, on mechanical ventilation, heart rate, these are all slightly near normal values, okay, with the pulmonary pressure slightly higher, okay. So, and in addition, what happened, we have our patient when they come out, because of, we have the inversive monitoring setup we have. So we have the arterial line to monitor the cardiac output rather, right? What's the pressure, invasive monitoring of the blood pressure, because they will be on supporting medicines. Rather, you might name this iron or vasopressors, and then all these things depend on the thing we try to. Okay. In addition, they have the pacemakers. Usually we have the epicardial pacing, we call the temporary pacing, because these patients can go into arrhythmias by the time we need to manage the heart rate the way we want. Okay, and we have our patients at the femoral catheter. That patient probably gone to the immediate what I mentioned, the patient has been to the cath lab before. So probably one line we have to look for the cannulating rather than catheterization procedures. Or else we don't do routine in our cardiac patients, most of it. But we can have it in case where the patient anticipated for a renal dialysis or a patient might need an intra-aortic balloon pump. Where immediate most of it, the cardiac output is not great, we might suffer with the intra-aortic balloon pump. Where it's a balloon which just distal to the subclavian artery. Where what happens, string and expands. During strings, it's generate negative pressure to facilitate the proper cardiac output, rather forward flow it facilitate. At the same time, during diastole, it's constricted. So during recoil, what happens? After recoil will perfusion through the coronaries, cardiac perfusion is better, muscle perfusion, heart muscle perfusion better, and brain as well. So we have it. Then in addition to the pulmonary artery catheter, which we know it's sent to the superior vena cava, to the right atrium, and its blood is floating through the right ventricle and pulmonary artery and lodging the pulmonary capillaries, which called pulmonary wedge pressure. To measure the different level, we can measure the pressures. Okay. So, in addition, we have the chest drains, because as we have talked before, we have put patient in air patient with coagulopathy. So we anticipate there can be some drain immediate post-operatively. So we leave some drain in situ. And it will be in the mediastinum, as well as in the pericardium, as well as in the either side of the pleural space. Okay. And then usually we leave the chest drains to connect to suction, that is minus 20 millimeter water, or else to minus 2 kilopascal. Okay. So here, what are the information? Because if you are a critical care medical officer, you are working in our ICUs, so they will be handling more. Usually, the anesthetist, medical officer will bring down the patient to the critical care, and they will hand over to you. Okay, this patient had a bypass operation, 3 bypass or 4 bypasses, with what type of cardiac function was preserved by the function or the status, and pump time was this duration, and there is a bleeding during the procedure, this much of bleeding has been noted, and how much blood been transfused during the procedure. These are all usual hand models. Okay. So as we say that, so in the CMDG, what is the morbidity mortality usually? It is around 2 to 3% mortality, because these are not bypass operation because these are the patients, as I say, they are already morbid patients. So you are operating. So there is a risk. We don't talk about another operation usually, but in cardiac, we explain to the patient the chance of dying in this operation, right? So when you do operate, then there's a chance, that 97% chance you'll be alright, you'll go home on day 5, but there's a 2 to 3% chance you might die of this operation. And there's, as we say, we induce the coagulopathy, there's a chance of bleeding, treated, 7% chance of they will have the bleeding in the post-operative. And out of them, certain number of patients will have to go back to the theatre, right? So that will be happening while patient on an SCCM. So we will get the consent beforehand, explain to the patient, we will take it. In addition, we must explain to the patient, you will more likely to get a transfusion, because the majority of the people will be getting transfusion after the operation. So we have to get the patient's consent for the transfusion. Any concerns they have in a religious belief that preclude transfusion. Okay. Patient undergoes it, we have. So other thing is, as we know, the patient has cerebral coronary artery disease. It's a moderate or small size arteries. Okay. So in all of the body we have other arteries as well of the same age patients, right? So the brain also same age arteries. So they can have the same type of disease there as well. Okay, in the kidneys everywhere. So we have to explain to the patient there's a chance. In addition, when we connect to the heart machine, what we do is we generate the pressure. What we all do usually, we have a systolic and then we have the diastolic pressure. Then we go talking about the mean arterial pressure. What is that? 1/3 plus diastolic pressure. 1/3 of the pulse pressure with diastolic pressure. So why is it? There is always a blood flow is a forward flow, but in a pulsatile flow. But in the heart valve machine, we maintain the mean arterial pressure. It's a static pressure. It generated around 65-70. It's a forward flow generated by the machine. So it has its own inherent problem. Now we are trying to make machines generate pulsatile pressure, but still not 100%. Okay. So we maintain a flat pressure, or what is mean pressure? Why is it important? I hope most of you are PG trainers, right? Because mean pressure, why is it important? There is a concept of autoregulation. So in the brain and the kidney all functioning at the pressure of 70 is enough to maintain, 60 to 70 is enough to maintain optimum function. So we target that with the heart machine. Okay, that's what's happening. So, so since as I say, in the cellular accidents can happen by when you have the occluded coronary cerebral arteries, it needs certain pressure to maintain flow through them. When you bring down the 60s, it may not be enough to maintain the pressure there. So patient can have especially small vessel disease patient can have a cerebral accident. In addition, intracardiac compression or anything, we can leave some foreign particle behind. So it can embolize, and we can thrombus can be formed, inadequate hypernizations. Okay, so all these things can happen for the cerebral accidents. Same thing can happen with the myocardial infarction. Okay, because when you do surgeries, longer durations, or inadequate anastomosis, or the flow through the graft, anything can cause them. And vulnerable heart, it's already ischemic heart. If it's not get adequate, it can get a myocardial infarction. And worst scenario will be, if it's when you have a trauma in the body, you get the swelling, inflammation. The same change will happen in the heart. Okay, so cardiac function might not be optimum immediate post-operative. Okay, immediate violence, so this can develop into congestion heart really, and even sudden death. So this is for the mainly for the bleeding they are talking about. So one of the patients of morbidity are preoperative details such as age, here we are talking about adults 70 years, and BMI low, and for a male even slightly higher, and low platelet count and functional failures. No, then artificial hypertonic and aspirin chloroquine medicines. And procedure factors, it is number of grafts, of course it's a time frame, how many grafts and all, because there's a chance of leak always when you have more and more grafts. And prolonged cardiac bypass time, if it's shorter the time, it's better outcome. Longer the time, prognosis is not great. And aortic cross-clamp time, again, shorter is better, and long is not good. And when it's a native aorta, it is aorta is a porcelain aorta, what you call calcified, and bad aorta, there's embolic chance and rupture and even dissection. All complications higher, so it's not great. And how we weaning of bypass. When we come out, it should be smooth. As I said, we do the hypertonic, arrest the heart, then we come up, we reverse the procedures. We start the lung ventilation, then we warm the patient, then heart should start with sinus rhythm nicely, that's good better. If it's with the arrhythmic storms, patient don't behave very well. So post-operatively, what are the problems can happen? Because what is in the theater, what's the usual temperature? It's around 22, right? 18 to 22 maintain. So when you do that thing, when we know, we bring the machine to the 37, but it will go up to 30 to 34, right? Then fluid overload. We can give more to get the pressure back. What is preload? It's a styling phenomenon, what do you call it? You know that. It's like a stage catabolic effect. So we tend to give more and more volume to maintain the pressure. So the preload, when fluid overload can happen indirectly. Then we give the blood transfusions and bleeding, and then anesthesia. Sometimes what happens, we collapse the lung left ventricle for a bypass operation. What we do, when we connect to the heart lung machine, we off the ventilation. So the lungs will collapse. So when you come up, some people will do the recruitment maneuver. They give some more pressure to expand the lung. Sometimes we don't do that. Why? There's a barrel from out the lung. So we deliver. That's why slowly we increase the pressure. But when you come out, the apical part of the lungs, sometimes we can't get there. So in that case, we maintain higher pressure post-operative. Okay. So these are it all about the flow. So how do you manage things? The risk factors, we give the body temperature, of course, we apply the warmers, right? We give the wet warmers and we cover the patient with the warm and iodine volumes we can manipulate. And mechanical ventilation settings, of course, and we manage the blood products. Okay. So this is a tubes which we don't have. I see the brain, the monitoring we don't have in our Sri Lanka. We have the normal monitors. No? So what happened? They're talking about chest tubes. Why do you leave the chest tubes? As we say, to have how much volume is coming. No? It's a different thing. What color is it, volume, and whether it's air is coming out or not. Then all these things you have to observe immediate post-operative. Why? Excessive bleeding can lead to hypotension. Hypotension means the preload is low, so the patient can go into analyze organ perfusion test as well, right? And this is a mnemonic you all have. You all get this print out, is it? Not print out, you get it? No. You get it. So you can make this is bleeding is concerned. When you have patient comes to ICU, when there is a bleeding, it depends that this is what you call Kirkland and Birmingham in Alabama. They have the criteria where the people are bigger people, no, compared to ours. People, American and English people they are quite big. So if 500 ml first hour, 400 ml next 2 hours, so 300 next 3 hours, so 1000 ml for 4 hours. So those are provably indication for operating. In our case, if a 40 kilo lady or 50 kilo lady comes, it's more. So we have 1 to 2 ml per kilogram. We are roughly, it's a surgeon's discretion, right? We give the product. So if it's 2 to 3, then 3 we than 4, we are really concerned. Unless we know deliberately the patient has coagulopathy, we will correct the coagulopathy. Or else we might have to take the theater to see why is it happening. Okay. So this is a rough idea. So we had talked about how do we correct that thing. So coagulation defect, it is iatrogenic, we give the heparin. So what is the antidote to the heparin? We give the protamine sulfate. Okay. And if the platelet disorders, we have to give the platelet. Or else, if the function is, we have to correct the function. For example, if one organ disease is suspected, then we have the desmopressin like that. Okay. And why these deficiencies are happening? Because we have the patients connected to the heart machine, as I say, the blood will travel through the tubing system, and then you have the oxygenator and it's filtered out. Okay, so during this procedure, patient can use a factor deficiency. In addition to the larger draw area, we have cut certain areas, so larger draw area there, so it's a consumption. Lot of clotting is happening in the raw area as well. So there is a consumptive coagulopathy as a certain localized. Okay, so we have to correct the things depend on the thing. So if you have heparin, what does it do? I say thrombin free. Then patient come with a warfarin or other nutritional problems, they have the 2, 7, 9, 10 deficiencies, no? So we treat with the prison plasma, or else in the more one cryoprecipitate. Why cryoprecipitate? Because it's a low volume, small volume, and it's high concentrate. Okay. In addition, we have some additional factors. So it's a better one, low volume, we can correct. Or else prison plasma problem, it's a larger volume we have, 50 ml per kilogram. So in the cardio, we prefer to go for cryoprecipitate most of the time. And most of the factors will be corrected with it. Now, what you will have? Now, in our setup, what we have rotom and MTEM. So we can specifically go for rotom. We can do the rotom, right? So we can rotom or MTEM or whatever is in Jaffna, we have MTEM something. So we can do specific factor and we can correct it. Okay. So hereditary conditions usually we have in the platelet transfusion. If a factor, so it's a platelet now we get one pack is a collected pack, right? It's from 10 people into single pack. It gives one pack, it gives around paralysis, and the people with each paralysis gives more volume. Earlier days we get one volume platelet, it's small, so you get 10 or 15 pack. Now it's together, they give it. It's a 60,000 6 packs, no, roughly. Earlier we taught us 10. Then thrombocytopenia, then you have to platelet. So you all can read this now. Really was by warfarin. Then again, warfarin, how do you manage? We do the FFP or right. So FFP is one idea. Then if not, depend on it. The patient with a mechanical valve, we can't give the vitamin K. Why? It's quickly it will correct it. So it will thrombogenic in the mechanical valve. So in the mechanical valve patient, we should correct with the FFP. Slowly we have to bring down. Right? INR. Unless it's a severe bleeding. Then these are factor 2 inhibitor dabigatran something we can give for a prothrombin complex, 4-factor prothrombin complex. And vitamin A sources, first line is that one, because when you have effective fluid overload issues, we can go back. We can give the 4-factor is first line, the second line for a dabigatran. And factor 10A inhibitors, that is, as we know when we gave heparin, what we test, activated clotting the ACT test, right? In other countries, we do the anti-10A level. Factor 10A specifically we can do, but which we don't have in Jaffna. Do we have? We don't have this. So in other countries, usually we manage with the factor 10A level. Okay, so in that case again, and other one for the activated thrombin complex, again it's available. That is for the factor dabigatran second line, right? And iodide it's mainly for first line for the dabigatran antidote, right? And antioxidants is of course we don't have, right? These are the factor 10 inhibitors, apixaban, edoxaban, chloroxaban, that is used FDA approval only. If you have valve issue, valve replaced, then we have to treat with the warfarin still for the FDA approval. For others, condition DVT and everything, we can go for factor 10 inhibitors, they will be on. So these patients can come to our patients, as the cardiac patients, they will have breathing disorders, they will treat the antioxidants. So I don't think it's available in our part of the world. So what is massive transmission? It's if you transfuse one total volume of the body, transfusion happens once, right? So if it's happened, what's the problem? You can't treat with a single component. Why single component problem? If you give the one component, others will have current deficiency. So to prevent that, we have to give 1:1:1. Okay, that is one fractionalized, one plated, and one effective, then the ratio, right? Or as 1:2, some say right? And depending on the things, we can give the desmopressin when it's subjected plated. And usually how does the blood collect? They give they remove the calcium in the blood pack, no? So the patient, when you transfuse the patient, they will go into hypocalcemia. What is cofactor for the protein production? So you have to treat the calcium also for these patients. Okay. What is cardiac tamponade? It is something that compresses the heart. Okay, it can be. It's inside the heart, inside the thick fibrous cavity. We call pericardium. So when the pressure builds up, it will compress the low pressure system first, but later whole heart will compress. So what is the low pressure? Right hand, atrium and the ventricle. So there is a preload failure. Okay. So how do you manage? It's one of these emergencies, right? In our cardiac immediate hospital, it's one of these emergencies. When it's leak, can collect it. So what is required? You say it is a hypotension, distant neck veins, and normal heart sound. Luckily, you all not find why you are auscultate now, no? Like, you are auscultate. No, so you don't know normal heart sound, that you will never know, but it will be the normal heart sound. Okay. When you auscultate normal heart, you will remember, right? Hypotension, of course, because it's a Parsons meter is there, you can, sorry, the arterial wave line, you can see that distant neck vein, so the CV will go up. Okay. So, and other ones you can, ultrasonically you can do the scan, you can have the echocardiogram, right? Scan is echo. What's the limitations? Because you have the pericardium is open and chest is open, so there will be air interface. So it might not be difficult sometimes. What happens when even the experienced cardiologists find difficult sometimes? Why? We see the relations when you do the echo. So here it's dissected and you don't find the relations as it is. So sometimes it's misleading. Okay, because the tissue source appears to be thick, edematous tissue also might be. But when you have doubt, we will open and see. Okay. So this is what would happen with the cardiac tamponade. Usually what happens, your negative thoracic pressure, interthoracic pressure, -2 to -6. When breathe, inspiration, we more increase negative pressure. So -2 to -6. So venous return will go up. But here it's other way around. When you do that, it's compressing, so what happens? Your CV will go up. Okay, so it's a paradox, right? And so you can notice the pressure, right? So why is it important? We have to take the patient together, right? That is ourselves, and in the other setup we'll open, maybe we open in the ICU itself. Okay. So other things, device, as we saw, what are the device? Patient can have pulmonary catheters, or we can have various femoral lines, all these things, and balloon pumps, and then we have the pacemakers, all these things can happen, right? So we need a sheet inside. So what's the problem related to sheets? Something if you leave in the artery, what will happen? It will impede the flow, disturb that, right? In addition, when you leave, artery is always positive pressure, so it can bleed and it will get infected. Okay, and what happens when you have the when there is a block, and there's a turbulence, then what happens? There's a chance of thrombus formation. Okay. So, and in addition, accidentally injure the surrounding structures. And in addition, what happens? Usually, what they do, they put femoral cannula and they travel through the aorta or in the femoral vein through the vein. They walk. So, what can happen? It's traveling in the retroperitoneal space. So, it can get damaged. So, it can give a retroperitoneal hemorrhage. With the arterial vein, there's a high chance patient can die of it. Right? This is, of course, usually done by the cardiologist to access because they can puncture through the needle avulsion. So when you remove that, you can avulse or damage, right? And most of the cardiac arrest is one very important. It's happened in the ICU or in the ward setup, right? In the STU. So it is called CALS procedure, right? Yeah, in the other countries they train, or the cardiac medical officers should know that. So what happened? Whoever witnessed the cardiac arrest immediately should start the CTR. Next person should start the ARM management, right? While third person, you have to call for help. As you start the CTR, call for help. So third person has to connect the patient to the monitor, right? So find out whether there's a shockable rhythm or non-shockable rhythm. So it should happen within 2 minutes. Okay, ideal setup. Within 2 minutes, we should shock the patient for a shockable rhythm. Okay, if it's a flat wave or you have the because as I say, we have the pacemakers, temporary pacemakers. So when it gets activated, they get the electric wave. That is not generating cardiac output. In that case, we have to switch off that thing and we have to maybe tamper out. So we have to open it and switch off and see ventricular fibrillation, then we have to shock it. Okay, if not, we have to give the compression. And if they open and compression, corrective process should be correct. So this actual occurrence is I don't know, it's slightly higher side, 0.7 to 5.2% of the cardiac arrest incident occurs usually early, right? And in our case, 50%, it's American data actually, it's 50% within 3 hours, 84% within 8 hours overall. But its survival rate is very good. And that's the most take-home message there. Compared to our other cardiac arrest, you CTR our cardiac post-cardiac arrest patients are better survival. The reason is this happening in the ICU and HDU setup. And most of them we know the reason. Because why? How do we know the reason? Because we all did not check the potassium in the morning. Right? Or else we don't see that. Right? Magnesium, all the correctable causes we should correct. Okay. And bleeding. If it's excessive bleeding, we know what's the cause. So you can correct most of the stuff, right? So most of it's arrhythmias, you can shock the patient, and if it's sometimes what happens, there's a conduction blocks, then we have the pacemakers. So we can give the pacemaker, start the pacemaker, that's it. And that's what you do, right? And hemorrhage, you can correct it. Cardiac tamponade, correct it. Hypoxia, correct it. Electroabdominis, tension pneumothorax, and pacing wires, failures, and ongoing recurrent cardiac ischemias, right? That's why I was telling you earlier. So, what are the complications of the devices, or rather our femoral and cannulation was the problem? We had pulses, extremities in post-cardiac patients, so we had to look at plastic surgeon was telling about, we should always capillary filling and peripheral pulses. So if you have good peripheral pulse, does it exclude the compartment syndrome? No. Right? Why is it? Because arterial pressure, how much? It's around 120/80. Okay. So you can get major, but the compartment pressure is above 30. What will happen? Tissue coefficient is about 30. Starting stage, you remember 32 millimeter mercury at the artery length and 17 at the venous end, 25 to 1. So whenever 30, your pressure is, capillary pressure is more than that. Okay. patient complain pain, patient is always fine. So, okay, so we have released the compression. Otherwise what happened, you have the pulse temporal does not exclude compartment, right? So high risk hypertension, diabetes, these all you know that, because these are all vascular pathologies the same. Okay. So arterial complications, around 10 to 17% of them. It's in our case slightly, I don't think we don't find more frequently. But there, why is it happening? Because they operate on more older patients. The 80s, 70s, 80s patient, they have a more complex vascular problem. So when they have more incidents. Shock, low flow, because these all will have already compromised circulation, will further down by shock, low flow, and then into the support devices and failure also. Another one is thromboembolic event. DVT incident. Again, all patients are not very obese usually. So in other countries, they are obese patients. They are minimally mobile, so they are highly vulnerable for the DVT. So almost all the patients will get the inaxaparin prophylactic dose post-operative. In our part, we don't give that much because our colors are very small and we early mobilize them. By day 1 onwards, we mobilize, so incidence are slightly low. And I think it's expensive. It's not freely available, so we can't give all the patients. Okay. So pulmonary embolism also. Recently we have one patient reported, but it was reported very late. It was after 3 weeks. While he was in home, he became short of breath. It was taken to the Cardiovascular. Yeah, they say he has found a pulmonary embolism. Okay, but otherwise it's very minimal chance our patient will pulmonary. That's one reason we don't investigate. So why pulmonary? Lack of anticoagulation, as we had accepted, immobility, and this inflammatory response, systemic inflammatory response is profound inflammatory response, and these are pragmasia. The Lawrence, you almost know very is the most in pregnant mothers, no? So removal of device, local anticoagulant, thrombolytic therapy, thrombectomy. And then another important problem is vasoplegia. The vasoplegia is the vessels are not constricting, right? So how do you usually in the post-op patient what happens? It's a systemic inflammatory response. One factor we are thinking about. That is more in some people compared to others. So in that case, what happened? How much you have a fire? There's a low pressure stage with the patient or with the shock line immediately. So they need more and more volume and more inotropic supports to maintain the pressure immediately, first 48 hours. Why is it important if it's happened? This is not a good sign. We might lose the patient sometimes. We can manage, but it's fine. No? Low mean arterial pressure, high cardiac index. Cardiac index is for the body weight, body surface area. How much cardiac output for body surface area? So systemic resistance. If less, heart will pump more because afterload is very minimal. So high index failure. And adequate cardiac filling pressure. If this is echo is fine, but you can't maintain the pressure. Okay, it can happen in other conditions also, that is sepsis, cardiac. So it is in our case it's very common. 5 to 20% patients reported, and so why is it important outside? It's because there's a more and more morbidity, mortality, and how we know that patient is predictable nature by some patient with the AC inhibitors mainly, and beta blockers very rarely. All these patients first on vasopressors before, right? How does the pressure antigens and all the things do? It's a vasoconstrictor to maintain this one. No? So when there's a dilate against hypertension, we give them to dilate the vessels. So immediate post, if you don't stop before 24 hours, the patient become vulnerable. Right? And surgical procedure per se, because our heart lung machine and major trauma, all states going to, and patients free of status, congestive heart failure, okay, and anemia, all these injection low, all can be disposed to is not covering overall complete cardiac morbidity and mortality, but they were mainly concerning about critical care team is bleeding, I think. So any questions you want to ask? Or nothing learned or something learned? So take home message, what is it? CABG, that is overall mortality around 3